It's time for our nursing tip of the week, and in this week's tip, we are talking about electrolyte replacement protocols. Most hospitals have some standing orders for electrolyte replacement protocols that can be ordered by the provider, and this allows the nurses to look at the patient's labs and order replacements. Now, before we get into the actual replacements, I do want to say a couple things. Electrolytes in the kidneys go like this, and patients' renal function can change throughout their hospital stay. I have seen providers order electrolyte replacement protocols on patients that should not have them because they are straight up renal patients. And I've also seen providers order these protocols on patients when they have normal renal function, and then later on their renal function is not doing so hot. So you always need to make sure you're checking out the patient's renal function. Most electrolyte replacement protocols will say they need to have a certain creatinine level or GFR, but when in doubt, always ask the provider if your patient does not have healthy kidneys. Most protocols will offer an IV replacement protocol as well as an oral replacement protocol. Oral is typically always best if the patient is able to adequately take PO. If the patient cannot adequately take PO, then we can give most electrolytes through the IV, and it can be through a peripheral IV, and some places even have protocols for central lines because central lines you can give higher concentrations. Once you have checked if you have the protocol, you've checked the patient's renal function, now you're looking at their electrolytes to see which ones need to be replaced. All replacement protocols are going to be slightly different. I try to find the most clear replacement protocol I could find on the internet, but to be honest, this looks different than even the one I use at my hospital. Here, this one shows if their level of potassium is between 3.8 and 5, you're not going to do any replacement. And if you are 3.5 to 3.7, you're going to give 20 milliequivalents IV or PO. Now, it also gets a little more confusing because some hospitals have a PO version of potassium that you cannot crush. So if a patient has a feeding tube, you're going to have to do the powdered form. So it does get a little bit tricky, but just know that potassium can be enteric coated and not allowed to be crushed. Only are you going to order the replacement depending on what their potassium level is. You're also going to order the labs to be rechecked for that level depending on whatever replacement protocol was ordered. So if a patient has just a little bit low of a potassium and you give them a replacement, you're probably just going to go ahead and recheck in the morning time. But if they have super critically low potassium, we're going to want to recheck that a lot sooner. I also want to mention that at some hospitals, depending on the level of the potassium and the amount of replacement protocol, your patient probably needs to be on a telemetry monitor because when electrolytes get low and we're replacing things, we want to make sure we're doing it safely because patients can have ECG changes from low electrolytes and high electrolytes too. So at my hospital, there's a different protocol for med-surg than there is for your telemetry patients and your ICU patients. There's also a protocol for magnesium here, and there's also a protocol for phosphorus, and we even have a protocol for calcium as well. But the gist of it is check your patient's electrolyte levels, see if they're a renal patient, see if they have the protocol ordered, and then decide from there, should this be IV or should this be PO? And that's pretty much it. Let me know if you have any questions.